Good afternoon, everyone. I am Cherie Dotson from the College of Pharmacy and chair of the 2015 MLK Health Sciences Planning Committee. And I am pleased to welcome you to our 25th annual MLK Health Sciences program. Each year, this event gives members of the U of M Health Sciences schools, colleges, programs, and units an opportunity to come together for the planning of this very special occasion. The members of the MLK Health Sciences Planning Committee are listed on the back of your program. And at this time, I would like to ask for them to all stand to be recognized. We are excited today to celebrate 25 years of programming. Please, another round of applause for that. Included in your program is a listing of our past programs highlighting our previous speakers and the topics that they have addressed for us. It is important to note that these events would not be possible without the support of our deans, executives, and program directors. So at this time, I would like to ask the Chief Operating Officer, Chief Executive Officer for the U of M hospitals and health centers, the deans of the colleges and schools of dentistry, medicine, nursing, pharmacy, public health, social work, the program directors for the Michigan Institute for Clinical Health Research, for the Office for Health Equity and Inclusion, and the directors of Human Resources and Service Excellence for the hospitals and health centers to please stand to be recognized. We thank you for your support. We appreciate your dedication to this event. In keeping with tradition, I would now like to ask everyone to please stand to sing the Black National Anthem, Lift Every Voice and Sing. Okay, just 1 minute.
Let our rejoice
So the MLK Health Sciences Planning Committee recently developed some student initiatives designed to get our student organizations engaged in issues of diversity. This year, proposals were requested for previous or future projects focused on issues of eliminating health disparities. Today, we would like to recognize the winners of this competition. For Category 1, previous projects, the winner is the Student National Pharmaceutical Association for their project entitled Interdisciplinary Influenza Community Vaccination Clinics. And for Category 2, future projects, the winner is, again, the Student National Pharmaceutical Association for their project entitled Girls Move. So at this time, would representatives of this organization please come to the stage to receive an award? And the organization will receive a $500 award for each of these projects. Okay. We're photo ops. All right, one more hand. So at this time, I would like to welcome to the podium the Dean of the College of Pharmacy, Dr. James Dalton, to introduce our keynote speaker.
Good afternoon. Thank you for joining us today. It's my honor to introduce our keynote speaker today, Dr. Marie Chisholm-Burns, who I just met in Tucson a short 4 days ago. Dean Chisholm-Burns is Dean and Professor of the College of Pharmacy at the University of Tennessee Health Sciences Center in Memphis, Knoxville, and Nashville. She also holds the appointment as Professor of Surgery in the College of Medicine at the University of Tennessee Health Science Center. She earned her BS degree in pharmacy and her PharmD degree from the University of Georgia, a master's degree in public health from Emory University, and impressively, she just finished her MBA from University of Memphis in 2013 while dean at the College of Pharmacy in University of Tennessee. So she's clearly committed to continuing her education. Dean Chisholm-Burns began her academic career at the University of Georgia College of Pharmacy in Athens, Georgia, and the Georgia Health Sciences University in Augusta, where she founded and remains the executive director of the Medication Access Program, a program which is designed to bring people with transplants the medicines that they need in Georgia. Prior to moving to the University of Tennessee, she previously served as professor and head of the Department of Pharmacy Practice and Science at the University of Arizona College of Pharmacy. Her area of academic expertise is improving health outcomes by novel methods of medication adherence and healthcare access. She's a prolific scholar with over 270 articles, books, book chapters, and abstracts in these areas. And she's received numerous awards and honors, and I'll read some of them, including the Robert K. Chalmers Distinguished Pharmacy Educator Award from the American Association of Colleges of Pharmacy, the Clinical Pharmacy Education Award from the American College of Clinical Pharmacy, the Daniel B. Smith Practice Excellence Award, and most recently, the 2014 Research Achievement Award from the American Pharmacist Association, among several others that she's received. She's also a Fulbright scholar. As I mentioned, Dean Chisholm-Burns and I just met in Tucson a few days ago, and I'm absolutely confident that she's got an interesting and energetic lecture for us today. So please join me in welcoming her to the podium.
Well, thank you, Dean Dalton. Good afternoon. It's great to be here. What the dean failed to probably stress a little bit is that prior to him coming here, his building was right across from my building in Memphis, Tennessee. So it really has a special feel to be here today on this special occasion. I caught up with some of my colleagues that I've been doing work with over the years, and Bruce and I used to go to Park City every now and then when in our department head days, so we certainly have a lot to catch up with, and I'm just so glad to be here. If you want to give me credit, it's okay to give me credit for the good weather, because I'm used to Tucson weather. And I have to say, I called Steve 2 weeks ago. I'm like, what's the weather? And he said, ooh. He said, what's the weather there? I said, it's freezing here. And he said, like, what's freezing? I don't know, like 40, it's cold. And that's what he did. And he said, 40, I'll be jogging outside in shorts. So it's all a matter of perspective. Then he said, Marie, pack. Pack a lot of stuff. And so I did just that. So when you guys roll around with my bag tomorrow, you might ask what the driver did at the airport, because he's picking me back up. He said, now you're leaving on Tuesday, right? I'm like, yeah. He said, you're leaving this Tuesday, right? I'm like, yeah. It's a lot of stuff in that bag. So again, you'll see what I'm talking about tomorrow. It is not a carry-on, so I feel sorry for George tomorrow, because he's going to be carrying that bag. So again, I'm excited about being here on this very special occasion with you. I bring you greetings from the city of Memphis. I also bring you greetings from the University of Tennessee Health Science Center, as well as the University of Tennessee College of Pharmacy. The University of Tennessee College of Pharmacy has been around a long time, since 1898. And during this 117-year period, we have had 8 deans at the College of Pharmacy. Just in case you weren't able to pick me out, I'm the one with the bright orange jacket. That's Tennessee's colors. I do wear it well. We're going to give Dick some credit here. He has an orange and white tie on, but that orange jacket I'm sporting. But there's probably a couple other demographics that make me stand out among the group. I'm the first female dean at the college, also the first African-American dean at the College of Pharmacy. So again, another reason why I'm proud and happy to be here. I, like many of you, have been afforded opportunities, so many opportunities, and I'm able to be afforded these opportunities because of the sacrifices, the vision, and the great work that many people have done over the years, including Dr. King and others. So I stand tall as you stand tall and proud, because we stand on the broad shoulders of many giants. So today, what I'm going to do is give you a snapshot, if you will, about a serious problem. And it's the problem of health disparities. And I'm going to build on the theme, Unity, Not Uniformity, a spotlight on health disparities. So I'm big on terminology. If you don't know the meanings of the words, it's hard to move forward, right? So I Googled this. I would say I looked it up in Webster, but no. I Googled it. It might have been Webster that Google went to. And I defined the terms, and you see the definitions on this slide. And it says unity is the quality or state of not being multiple, a condition of harmony, a condition of being made one. Uniformity, on the other hand, is a quality or state of being the same or being identical. And sometimes these terms are used interchangeably, but they're not. Sort of like the conversation I had with my son last week about fair and equal. Not the same thing. Okay. So uniformity and unity. Then I started contrasting the terms. And I said unity is fueled by a shared vision or purpose. Uniformity is driven by one vision. Unity puts freedom first, whereas uniformity generally puts order, restrictions, and rules first. Unity is present when people want to obey. Uniformity is present when people are generally forced to obey. Unity is facilitated through relationships. Through relationships, and that's very, very key. Whereas uniformity is facilitated through limitations. So very different terms. So today we're going to talk about using unity, not necessarily uniformity, to achieve quality health care for all, while at the same time understanding and respecting differences related to experiences of disease states, responses to treatment, and cultural perspective on health and health care. And as you look around this room, and for some of you who have been here longer than others, you could attest, even in this room, probably the demographics have changed a little bit over time. And I'm seeing heads nod, so I'm sure that's the case. You're a sample of the country that we live in. And so we have a changing U.S. population. Let's start off with age. And this slide does a good job. It starts back in 1950 and it goes up to what we predict it may be, or estimate what we may think it might be in 2050. And what you see, if you look at these two numbers, is the greatest percentage of change will occur in the 65 years and older group. So what does that mean to healthcare providers? What does that mean to you as an individual? It means that people are living longer, and they're living longer with chronic diseases. We also see, at the same time, racial and ethnic demographic shifts that are occurring. So what you have in this slide, the green bars represent 2012. The orange bars represent what we believe or estimate what's going to happen in 2060. And I'm just going to point out a couple of things. Let's take this bar, the second bar here. You can see that the non-Hispanic white alone group, roughly 63% of the population, predicted to be around 43% of the population in 2060. And that 20% decrease, as well as this 9% difference right here, is really dispersed among these other subgroups. So changing demographics. So think about that as I talk about, as I go through this presentation. And hopefully we have a chance to have a great discussion. So I was preparing for this talk. I said, you know, the many health disparities talks in my day. I said, well, this one is special. And I have to admit, and maybe sadly, it was the first time I ever thought, what would Dr. King, or what did he think about this? Okay. This was a time, probably many of you as I look around the room, that we weren't around. I was 1 year old when Dr. King died. But I know from what I read, from what I see on TV, from all these things going on, from what I hear my parents talked about and others, and some of the things that I learned this morning, is that it was certainly a time of great civil unrest and questioning. So what about health? What did he think about health? Then I found this. He said it in 1966. He said, of all the forms of inequalities, injustice in healthcare is the most shocking and inhuman. And it just radiates, doesn't it? Of all forms. And if you could think about that, anyone who's ever been sick, and if you haven't really been sick, or if you had a loved one that has been sick, you know what I'm talking about. You know, it's nothing like a dose of reality, a walking out of an ICU, and it's your loved one in there. Okay? It snaps you back into, all this stuff that we tend to wrap our hands around and get angry about and all that other stuff, meaningless at that point. And you'll cash it all in. You can have my check, you can have my car, you can even have my firstborn to change some of these things. Healthcare, he said it. This is the most shocking and this is the most inhuman. So that was in 1966, almost 50 years ago. Then a short 6 years later, another king stated these words. Coretta Scott King in 1972. She stated this: "We can together do a lot more than we can being separated and divided." Now this wasn't in relationship to health care, or was it in relationship to health disparities, but it certainly has a ring of a solution. And so as I talk with you today, and as we have discussions, and as you think about this, and you see your patients, and you continue on with your education, I want you to think about this unity theme, because it affects all of us. And hopefully during the talk, I'll bring this closer to home. So again, unity. Health disparities, in a nutshell, what is it? It's differences in health outcomes that's due to systematically experienced increased barriers to good health and health care based on several factors. Could be one of these listed here, or it could be compounded, include several of them. So, what are the factors? Racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, and then other characteristics. My slide was full at this point, so this is the catch-all. Other characteristics historically linked to discrimination and exclusion. So you fill in the blank if I didn't list it. But let's drill down further. Let me give you some examples of these factors. Poverty and low socioeconomic status. So poverty and low socioeconomic status. Lack of health insurance, and we can't have that discussion without talking about the underinsured. Lower educational level, lack of preventive care, limited number of underrepresented minority health professions, and I'll bring this home in a few minutes. Limited access to health care, poor health literacy, and lack of trust in the healthcare system, whether it's perceived or whether they have objective data to support that. So all of these relate. What we do know is the consequences of these disparities. There are so great, these consequences, and they include higher mortality and morbidity rates, greater burden of disease and disabilities, reduced quality of life and low productivity, and increased cost. There was a study published in 2009. And they said if we could avoid health disparities just related to race alone, we could reduce direct medical costs by almost $230 billion. And if you add in the indirect cost with that, it's around $1 trillion. And this is all within 3 years. All within 3 years. It's tremendous. It's tremendous. So, if you get a little free time and you want to learn all about disparities, AHRQ put out an easy download. It's about 250 pages. I'm going to give you the take-home story on some of this, so you don't have to worry, because I know you got other stuff to read. But if you go to their website, and if you need this website, because it might be hard for you to see it there, but if you go to the AHRQ website, and I can give you this after the presentation. Again, free, easy download, and it does a really good job on focusing on disparities in healthcare delivery related to racial and socioeconomic factors. But what I would like to do is kind of hit 3 of these factors, and I'm only skimming the surface on this. What they did is they collected a lot of data, and they did this over time. So this is not the first time they put this data out. They surveyed patients, they surveyed patients' families, they looked at registry data, they looked at CMS data, they looked at all sorts of things, even hospital surveys and things of that nature. And I want to talk about these 3 areas for 1 minute. They looked at quality, access, and disparities. They also looked at things across several different disease states. So again, if you're interested, go to the download. And they used these measures to come up with some metrics, and they scored it, okay? And it doesn't really matter if you agree with the score or not, because I'm a person that goes back to the raw data, okay? And then I can make my own conclusions from that. But what they said about quality, and again, this is only US statistics, they gave it a rating of fair. And they built that around these measures that they looked at it. And one measure was they asked people of the recommended care, or care that was recommended to you, how much of that did you actually receive? So we could argue or debate, was that recommended care necessary or not? But let's assume it was necessary, okay? 70% of them said they actually received the recommended care. Now, I'm a faculty member. So what that means to me is 30% of them didn't. So 30% of your 70%, that makes your entire 100%, you didn't receive. Maybe that 30% might have been the stuff you actually needed, right? So 70%, but they said that's fair. And they actually said that there's large variations across states. In particular, the New England and North Central states were performing better than others. Then they said the change over time. So since the last time they did the survey, a few years back, and they said it was getting better. So me, being who I am, getting better, what does that mean? Because you got 70% on this. You know, my kid comes home with a 70. I'm happy it's not lower, right? But I'm not, that's not award winning. So they said it's getting better because the last time they did it, it was like 67%. Okay, all right, gotcha. Then they looked at areas of improvement. They saw areas of improvement in hospital care, CMS, publicly reported measures, and adolescent vaccinations. Areas that lagged was ambulatory care, diabetes care, maternal and child health. And then they looked at the geographical regions, and they found that West South Central and East South Central states weren't performing as well. In terms of access, they rated that as fair, just like quality. And they said, 26% of the population in this that was surveyed indicated that they had difficulties getting care. And they said that was getting worse over time. So what does that mean? So I had to go back to the last report. Roughly 24% in the last report talked about access difficulties. Improving areas included availability of providers by other things that's not direct, such as telephones. Things that were certainly not improving included private health insurance coverage. Okay? Then we looked at disparities, and they gave it a rating of 4. And they said minorities and people in poverty had worse quality and access issues for a large proportion of the measures, and we'll touch upon that in a few minutes. What was the change over time? No change. And to me, that's poor, if you don't know what I mean, because it was already low, all right? So no change on top of that. The disparities that we noted that were getting smaller included HIV disease and patients' perceptions of care. The disparities that were getting larger or bigger, cancer screening, as well as maternal and child health. So these are some of the key factors. So I looked into this quality of care and I wanted to see the measures, and I'm going to point out quickly a couple of things here. Poor versus high income, getting worse. If you look at the Black and Hispanic versus the white, here, at best the same, but many measures are getting worse. How about barriers to care? And I want you to keep in mind, this is individuals' perceived barriers to care. And they did this by race and income. And what they found is, so the higher the line here, is that Blacks and Hispanics had perceived themselves as having higher barriers compared to whites. Let's look over here in terms of income. You have the poor, you have the low income, then middle, and high income. And you could see with lower income, which is the higher lines, greater barriers. Nothing really surprising with that. Uninsured. And I wish they would have looked at underinsured, but that's kind of hard to capture. Just out of the uninsured, a couple of points I want to make again. And we talked about some of this last night when I met with the students. Poor, biggest percent of uninsured. All right? Just kind of seen that in the last slide. However, let's look at education. Less than high school, you are more likely to be uninsured. These two factors are highly linked. Highly linked. And again, I won't repeat what I said last night, but this kind of brings home the point that I talked with the students about of how important education is. So to summarize, some improvements have been made. However, there's considerable work that still needs to be done in healthcare quality and access. So I'm going to change the tables a little bit. I am a pharmacist by training. So I'm going to look through this through the eyes of a pharmacist and some of the research that I have been involved in personally over the last 15 to 20 years. So this was a paper that my colleague and I published while I was out in Arizona. And Arizona, every state, or I should say city or community, has this uniqueness to it. Lots of rural places in Arizona. See, Jim, all you know about is Phoenix and Tucson. But I could have, we could have went away maybe an hour or so, and you're like, Marie, I can't get my telephone reception out here. So it's lots of rural areas in lots of our states. But what we wanted to do, and we weren't able to find it, so we created it ourselves, is to have one paper, Simplified Life, have one paper that looked at disparities but disparities associated with medication use. Okay, and we wanted to have a comparison group, and it didn't exist. So not only do I like to look up words and terms, I like to make up words too. So I invented this word, pharmacotherapeutic disparities, according to this term, and that's defined as disparities related to or caused by desperate treatment with medications. And so this was basically a literature review. And you might say, well, Marie, why is that important? You know, why are you spending time on that? Well, I'll tell you why. It's real simple. Because in this country, understandably so, that medication, prescribed medications, even some over-the-counter, but prescribed medications is the predominant treatment modality that we use to treat chronic diseases. And you see it on the ambulatory care basis all the time. And we already talked about where we're at with ambulatory care. I already passed that. So this study, and I just gave you the take-home points for this, is that if you did a random sample of people in the United States, of adults, and if you looked at it, approximately 1 out of every 2 are on a prescribed medication. So I'm not even counting over-the-counter medications. Approximately 1 out of 3 are on 2 medications or more. And approximately 11% take 5 prescription drugs during a 1-month time period. We use medications. Okay. Me being a pharmacist, I'm kind of okay with that. That keeps me employed when the medications are used properly. So that's why it's important. So if you don't get the medications, there's a problem. You're not treating the disease state. We could draw that conclusion, right? And no wonder you see differences in the outcomes. So I'll save you the study steps, but just know this. We had a bunch of articles. We boiled it down to 311 articles. And not surprisingly, 77% of these 311, which is about 240, noted significant disparities in drug treatment across race, ethnicity, and gender, with the most frequent disparities being differences in receipt of the prescription drug, drug prescribed, dosage or administration method, and waiting time to receipt of drugs. And you and I kind of talked about that last night in the ER when I said, just give him the Demerol. It's a sickle cell patient, okay? So, some outcomes associated with drug treatment disparities. Again, we talked about it, but increased hospitalizations, decreased survival time, especially when you look at the oncology studies and the HIV studies where the 5-year survival time is significantly less, and decreased achievement of therapeutic goals such as target blood pressure. This slide sums it up. I know it's hard to read, so I'll kind of hit the high points. Again, this was published in American Journal of Health System Pharmacy back in 2010. And if you can't get it, I could get it over to you. But just to give you a flavor for the diseases that we saw across the spectrum: asthma, cardiovascular disease, diabetes, HIV, mental health, big one, oncology, osteoporosis, pain control or palliative care, Parkinson's disease. It crosses all different spectrums. Okay. So, at the end of the study, we had these 311 articles, and I like to put stuff in buckets. I just can't remember as much as I used to. So you got to really break it down and make it simple for me. And it really fell. Factors contributing to these disparities in 3 areas: patient-related, provider, and I'm going to call it the system. So let's start bottom up. We do this slide. Patient-related. This is identified as racial and ethnic minority, or as female or different attitudes across race, ethnicity, or gender, language differences, a huge one, I don't know how many times I've walked the halls when I was in Arizona at the hospital, and there is a 7-year-old being the interpreter between the physician and grandmother. Okay? Now, one time my son was 7 years old, and we speak English most of the time. And I could say something to him, and then my husband comes in the room and said, "John said you said this." No, I did not say that. So I just could only imagine. Now, John's was probably a little intentional misinterpretation. But something as difficult as health, disease, treatment, for a 7-year-old to be the interpreter. Provider. Now, this may be influenced by social contexts and cues and stereotyping and other uncertainties. But let's talk a little bit about the system. And this is lack of adequate access to healthcare providers, and in my case for this study, treatment options, which really means medications. And I could point to 2 studies. And briefly, I want to talk about the first one. This was a study that was done in New York City. I could say this because I'm born and raised in New York. I'm not exactly sure if you call my pharmacy in New York City that I will tell you that I have a bunch of controlled narcotics in my safe. But this is what they did, and I'm not criticizing the study because it gave us some information. And what they found that pharmacies in areas with fewer white residents were less likely to have adequately stocked narcotics. Okay. An access issue. Then I'm going to bring it home for you right here now. Good colleague of mine, we worked together on the NIH grant. I called him up. I appreciate that, Steve. He came to my rescue because I was in trouble. I needed some quality of life stuff done on my NIH grant. And he published, I believe it was last month. Was it last month in the APA journal? Right locally, Wayne County, somebody made 550 calls, well, at least 550 calls, because there was 550 drugstores in this study. And he looked at the zip codes. And so I guess Steve Erickson and Paul Workman, we have to thank you, because this is what they found. They found that zip codes with higher household income and percentage of white residents had lower levothyroxine prices. So let me go back a little bit. What he did was he asked, and then if you have some problems with the study, that's Steve right there. What he did was that he picked a generic drug. We also picked a brand drug too, but we didn't see any significance there. And a common drug, generic Synthroid. And so they just called around to say, hey, how much would this prescription cost? And got some as you're paying cash for these medications. So no insurance, no coverage on your prescription medications. Then I guess while he had them on the phone, he asked them a bunch of other questions. He asked them about, do you offer any generic drug discount programs? What's your hours of operation? And do you provide immunization services? So now here we go. He found that zip codes with higher household income and percentage of white residents had lower levothyroxine prices. Greater percentages of these pharmacies offered discount drug programs. They had more hours of operation during the week and more pharmacy-based immunization services compared to the lower incomes and the non-majority places. Right here. Right here. So it's good for us to identify the problems. Then it takes us to the next step. Okay? So just think about this right here. So how do we fix this? I'll tell you right now, it is not a quick fix thing. It's just not. But it involves unity. Mrs. King talked about that. It involves increasing capacity and elements of individualization, so individualization as well as fairness. It's a time to dream, but also a time to act. And I'll throw in my pharmacy here, using multiple mechanisms of action. And so as we think about things like increasing capacity, and that's why I'm so glad that our accrediting bodies, I can't say they got together, because if they got together, we wouldn't be having the logistic problems that we're having with IPEs, but Interprofessional Education, but at least they're recognizing it. And what I see out of IPE or Interprofessional Education is that diversity is a foundation and an excellent place to instill unity to help combat health disparities. So I'll share with you this slide. Found this cartoon. This is a patient, family member, friend standing next to her. She's looking out the window. Could be here, except your colleges are spread further apart than that. But just imagine if they were closer. And you got medicine, and you got pharmacy, and you got nursing, and you got all these places. And this is what she says. How can they work together if they don't learn together? How can they work together if they don't learn together? So Interprofessional Education, and I'm the abbreviation queen, so IPEs is defined as students from 2 or more professions in health and social care, learning together during all or part of their professional training. This is the key, with the objective of cultivating collaborative practice for whom? The patient, to improve patient-centered healthcare. So I was so excited when I heard that this campus received a large grant for interprofessional education, where it's bringing several colleges together. I think it's pharmacy, nursing, social work, dentistry, public health, and kinesiology. I believe those are the 7. And I might have, if I missed one, I'm sorry. But I believe those are the 7 colleges that are working together on this. So I'm going to have my eye from a distance to see what happens with this here in the future. At the Health Sciences Center at the University of Tennessee, we're doing the same thing, and so we're erecting a building. The Fort building, Jim, is coming down. Yeah, I know, that is you guys don't understand. That is a whole other health disparity in itself. So the Fort building, long overdue, is coming down. And we're going to put up this building. I believe it's somewhere in the neighborhood of 45,000 square feet. And that's where we're going to have our simulation centers in there. So we're gearing up for that. Meanwhile, for a long time in the city of Memphis, we have used our students. We have a very active SNAFA chapter, and congratulations, SNAFA. Good job. Well done. We have used our students to try to improve health in the greater Memphis area, and they're side by side with medicine and dental students as they go out, as well as nursing students. So what other recommendations do we have? Well, we could employ technology to reduce and eliminate health disparities as well. And I know I'm not the only one here. I probably should have worn my black Fitbit band. But stuff like this, right? And I bet you a large population in here has Fitbit, and we monitor stuff, and we go back to our phones, and we compare stuff in terms of steps or heart rate or sleep patterns is the big thing. And so we can use that type of technology. I know the way I interacted with my patients 2 years ago compared to 10 years ago is very different. It's like email me, text me, remind me, text me, okay? So that sort of thing. So we can use this technology. What I would like to do is play you a brief video of technology in healthcare. And for those of you who have been around for a while, just reminisce with you.
Hi, Dr. Connors.
Dr. Connors, how are you?
Can I see you try to touch the tip of your nose?
Your attention pneumothorax that you have to worry about.
Things have changed. Things are constantly changing. And so we could use technology like this, technology that is even more advanced than this. In the September issue of Time magazine, and I even have this someplace else, I keep it with me, and it talks about we're never offline, and we're just not offline ever, okay? And we're always accessible, maybe that's good or bad, but we could use this to monitor, connect to these geographical regions that we weren't able to get to. What you saw there was some telemedicine going on. We could go to those rural places in Arizona. Before, we couldn't. We had to drive, okay? So we could connect. We need to think globally and act locally. So for the School of Public Health, that's my MPH coming out of me. Think globally, but act locally. Do what you can where you can in your communities. Identify stuff, try to fix stuff. But at the same time, just realize that we are all connected. All connected. And I'll share with you a story without trying to reveal the state or the city that I was in. It was a pretty affluent place, and we saw an outbreak of TB. Oh, so we don't have TB. Their kids started having TBs. Oh, we don't have TB. But you do. And what we found is that it was their domestic workers, the poor, the less fortunate, the uninsured, who kept their kids. So if you think it doesn't affect you, it does. It really, really does. Because now your kid has TB. And this is where it came from. Maybe if we did a little bit of some treatment over here, we wouldn't be treating over here. So we are all connected. And I don't need to remind you a couple of months ago about Ebola. I mean, I spent half of my life in the airport, right? Somebody's central supply got knocked off. I've never seen so many masks. Okay? It changes it. We are all connected. International travel, social media, people migrating, we are all connected. So it affects you. You, me, we make great incomes. We have health insurance. We have a car to get there. It affects us personally. So if you never thought about this in an altruistic way, think about it in a selfish, stingy way. It affects you. So you have to be concerned about it. This is not an inner city Detroit problem that you talked about, Steve. It's not an inner city Detroit problem. It's not a South Central problem. It's not rural Arizona's problem. It's not the south side or the west side of Memphis problem. It's not your problem. It's not my problem. It's a health problem, and it affects each and every one of us. So we have to stress accountability in healthcare delivery and quality as well. It's a little scary because when we measure things, people think about liabilities and all sorts of things. But that's the only way that we could change it. We have to have a scorecard. We have to do other things too. Ensure a strategic focus on communities at greatest risk. Again, unity, not uniformity. Reduce disparities in access to healthcare quality. Increase capacity of healthcare workforce to identify and address disparities. Support research in this area. and standardize and collect data to better identify and address these disparities. What I'm going to do is focus for the remainder of the presentation on these three things and relate it to some of the work that I've been involved in over the years. So let's talk about reducing disparities to access to quality health care. As Dean Dalton told you, my roots are back in transplant medicine. Started in kidney transplants, now I do all solid organ, liver, lung, hearts, kidneys, pancreas. And what I noticed when I was at the Medical College of Georgia, now called Georgia Regional, is that my kidney transplant patients weren't taking their drugs. Now, how can this be? You got a kidney, a new lease on life. You waited 3 years on the waiting list for this. How can you not take your medicines? Then I stopped judging and I started asking questions and looked for sincerity. And it didn't take long to find the answer to some of it. They can't afford it. And as I started looking at the prices of these medications, I would be strapped to afford it. You're talking about medications that are $20,000 to $30,000 to $40,000 a year for your outpatient immunosuppressants. These people have a transplant for a reason, which means they have other diseases too. Hypertension, diabetes, other chronic diseases, the list just goes on and on. Since they're immunosuppressed, we have to give them infectious disease medications, so it's stacked pretty high, and it gets pretty expensive. So we needed to do something about it. And so I utilized what I had and the people that were around that I could utilize their skills as well. And not only did I start collecting the data to get published and things of that nature that we all do as faculty members, but take it the next step. What can we do about it? So I used that platform to get funding, and then MAP was born. So MAP is a medication access program, and the mission of MAP is to increase access to medications for solid organ transplant recipients. It is a statewide program in the state of Georgia, has been fully funded for years now. Since its inception in 1999, MAP has helped more than 800 of Georgia transplant recipients receive approximately $54 million in medications. The large percentage of this really comes from the pharmaceutical manufacturers' medication assistance programs, about $46 million. The other 8 comes from Medicare Part D programs. Okay. And if any of you have utilized these systems, you know that it's hard to navigate. It is not easy, all right? It's not easy. So what this program does is that it collects all of the medication information that the patient is taking, including over-the-counter medications. It does something like a medication therapy review for all of these individuals on a quarterly basis. And it also takes into account their financial profile, so we can find the best programs that fit them to get them the medications. So I did this for a while back in, I don't know, the mid-2000s. I said, well, I know the patients are getting the medications. I wonder, is it changing their outcomes? So in 2007, my colleagues and I, we published this paper, and I'll quickly walk you through this paper. So the first question I wanted to answer, did we improve access? So this is before and after data. So I said, well, one way we perhaps could get to the answer is that a lot of the disease states that they have require multiple medications. Antihypertensives, you know, my patients are 3, 4, 5. It gets steep. We put them on lots of medications for blood pressure. If they don't have hypertension coming in, they will have it. Just give it time. Diabetes, anti-diabetic medication, and then we also looked at lipid medications. And what we found is 1 year after being enrolled in MAP, that the number of medications in these areas did statistically and significantly increase. So how about clinical indicators? In the nutshell here is that we affected every clinical indicator that we measured, which which included fasting blood glucose, hemoglobin A1C, cholesterol levels, LDLs, triglycerides, blood pressure. We even looked at the immunosuppressants, the calcineurin inhibitors, and graft rejection. Everything had improved except for the tacrolimus level. Perhaps they didn't need to. So that was statistically significant. We also looked at quality of life, and I'll be honest, Steve, I didn't think anything was going to change with this. Point in time, you asked me something, I'm feeling pretty good today. You know, my plane doesn't leave on time tomorrow, give me a quality of life scale, okay? Has nothing to do with my health. But we did influence some scores. We saw higher scores in general health, social functioning, role emotional, mental health, and the mental component summary of the SF scale. So increased capacity, I'm going to move on to increased capacity of healthcare workforce to identify and address disparities. And I'm going to share with you something that the IOM, the Institute of Medicine, said years ago. And it talked about increasing diversity among our health professionals is associated with many benefits, including improved access, improved patient satisfaction, better communication with patients, and more effective education of health professional students. Imperative. So we're talking about an educational component as well as a healthcare component. You can look at the studies, but there are studies out there that suggest that minority healthcare professionals are more likely than non-minority to work in the underserved as well as minority populations or communities. So it really gets down to the patient. But let's just think about it in education in general. As diversity in health professions education also increases cultural awareness, improves cross-cultural training and competencies, it challenges assumptions, stereotypes, and biases, and it broadens perspectives on racial, ethnic, and cultural differences. And as a result, our students are better prepared to interact in what I call the real world, and looking at people in perhaps a very real lens, instead of a lens that maybe they thought they had a stereotype associated with it. So it really, really does ultimately facilitate improved patient care. So, as I said, I'm a pharmacist, so I do things related to medications in pharmacy schools, and I'm in a pharmacy school. And so back in 2012, we published this article in the American Journal of Pharmaceutical Education. And basically what we looked at is that we wanted to look at trends in numbers of women and underrepresented minority faculty members in pharmacy over the last 20 years. Okay? Again, many faculty members have co-funded positions, or they're role models, and they work in hospitals, clinics, different pharmacies. And so we wanted to look at that data, and then we took it a step further. We wanted to create a model. So we had some qualitative and quantitative data that looked at factors that influence recruitment and retention of academic pharmacy career individuals, again, faculty members. So when we looked at the women, the females, the women data of pharmacists, or should I say faculty members in the College of Pharmacy across the United States, so we did depend on AACP data, and that's reported data. And we looked at this over a 20-year period from 1989 to 2009. And during that time, we did see huge increases in women faculty members. However, when you look at the underrepresented minority faculty members, and I'll show you the patterns, it did something strange. It was roughly stagnant, and it was peaks and valleys, and it was ins and outs. So let me start off with the women data. Briefly, what you have in this slide is several line graphs The y-axis is the proportion of total faculty members. So this 0.8 represents 80%, 40%, 10%. This dark line here, I'm going to call that the pipeline. That's the number of pharmacy graduates that we put out during those years, which is on your x-axis. Because that's the entry point. Now, we could talk about residencies, fellowships, graduate school, we could do all that. But that's the entry point that we used for our study, because AACP had that data available. This next dotted line represents assistant professor, associate, and in here you have full professors and administrators, department heads, and deans. And for those of us who are academics, we get it. This follows a pattern that we could understand. Not everybody goes into academia. We see a nice slope. 60% is good numbers there. We see this assistant professor line increasing, okay? Right here from about 35% to well over 50% of total assistant professors are women. Then you expect to see associates to be lower, and then full professors, deans, and administrators to be at that level. Which, you know, again, the associate professor line looks like it's well over 30%. Underrepresented minorities, the first thing I have to tell you is I changed the axis. Because those high numbers of 60%, 0.6, it just would not work. Everything will be squished at the bottom here. So the highest that you're seeing here, where the other one was like 80%, I think, this is 16%. Just to give, so you can put this in perspective. Same thing. Okay, there's the pipeline. Okay, and you can say, well, maybe this should be shifted over. We could talk about that because it takes a while for people to graduate, get into academia. Okay. However, what you see is a little concerning. Your assistant professor line is up there. At some points, it almost kind of crosses over with the pipeline. That speaks volumes. Then you see the associate professor, okay? Then you see the full professor. You don't see a nice slope, you see peaks and valleys. And I just don't get it, maybe a topic for discussion, that you also have deans up in here. Again, it's not much. We're in 10% to 12% was peak at maybe around, I don't know, this is even for the pipeline, it's 16%. The problem is clear just by looking at this. So at the end, we came up with this. You have to have a pipeline. You have to have a pipeline, and when you hire a lot of people, a lot of academic organizations put a lot of stock in recruiting, and they should, that's great. But it doesn't stop there. You got to make sure you recruit not only the right person, the qualified fit, but in the area that you could academically support. It has to be a good fit because you want that person to be successful. Nobody wants to hire, you're talking about a lot of money, startup costs, we won't even get into that. Someone that's not successful. We all lose when that happens. So recruitment is very important. And realize you're just not recruiting to the University of Michigan. You're recruiting to Michigan. You're recruiting to whatever communities they're going to stay in. You're recruiting to the environment. You're recruiting to the climate. And when I mean climate, I know you might think after the beginning of this talk when I started talking about the weather, but I'm talking about climate as in culture. It's everything. And then you got to focus on retention. So we're going to see natural ins and outs. That's the job market. Things happen. People move on, new opportunities. Okay? And I call those successes as well. But you want faculty sustainability and advancement because you need those role models because that's where your pipeline is looking. They need those role models. And so it is a cycle. It is really a cycle. So the last bullet, to support research to identify effective strategies to eliminate health disparities is very, very important. I could put up many studies, but I won't. And there's no particular reason why I selected this one. I guess I was in the mood to stay on the transplant theme with blood pressure. So this is a study that my colleagues and I published several years ago in the journal Ethnicity and Disease, and we looked at African American renal transplant recipients. I told you renal transplant recipients are prone to hypertension anyway. The African American population is even more prone. That's the problem. And so we, after receiving informed consent, we randomized patients into one of two groups, the control group. In the control group, they received usual care. In the intervention group, they received usual care plus clinical pharmacy services, where we helped them get their medications. We talked to them about their medications. We connected the dots so they could understand their disease states and their medications and how it all links together. We sent them reminders. We did everything we could. And what we found over this year time frame is that we saw a significantly lower blood pressure. So blood pressure improvements in the intervention group compared to the control group. So we have to use all of these mechanisms that I talked about, all of these methodologies, recommendations, and some, you guys are more creative and certainly a lot smarter than I am. We have to use this, because what we need to do is change the narrative from health disparities to one that Dr. King talked about, which really makes him seem very much more so in my eyes as a visionary, because he saw it 50 years ago and we're just getting around to it now. One of health equity. So from disparities to health equity. And so in the new Healthy People 2020, they talked about health equity for the first time. And they defined this as attainment of the highest level of health for all people. And what does it require? I could read this stuff like you can on this slide, but basically what that says, it requires what his wife said in 1972. It requires unity. I just talked to you about how we all are connected. You think it doesn't affect you? It affects you. Nothing like seeing a parent whose 7-year-old has tuberculosis. It affects you. Okay? So we have to change this discussion. So in summary, I hit upon several things, looked at the factors that contributed to health disparities, and these health disparities, we talked about the devastating consequences. We made some improvements. We know the population is shifting. Things are happening quickly. And yet, health disparities remain. To address this, we must focus on unity, multiplicity, accountability, I can't stress that enough, and the dream. Dr. King once said, "Injustice anywhere is a threat to justice everywhere." I submit to you today that poor health and poor health care anywhere is a threat to health everywhere. So we have to keep this vision that he talked about many, many years ago, also what he identified and spoke about in 1966. We have to keep this vision alive. It affects all of us. So again, at this point, I want to thank you for inviting me. I'm just thrilled to be here. I don't know if we have a couple of minutes for statements, questions, or whatever. If not, we can meet outside. I'll be around. But again, I'm excited to be here. And thanks so very much for allowing me to spend this special day with you. Thanks so much.
That was awesome. Thank you. we do have a couple of minutes for questions. Before doing so, I'd like to present Dean Chisholm-Burns with a plaque recognizing her lecture today. That was fantastic. It exceeded my expectations, although they were high already. So thank you very, very much. So this is just a plaque that in recognition of your service as the keynote speaker at the 25th annual MLK Health Sciences Program. Thank you very, very much.
Well, thank you, Jim. I appreciate it. Thank you.
If there are any questions out there, we can take a couple, and then we're going to have
I think we have one
reception
back there.
outside in the back there.
Sure. So I'll repeat the question. The gentleman asks, any comments about the Affordable Health Care Act? Well, it's a lot of that has remained to be seen. I could tell you how it has affected not the underinsured, but the uninsured. And I talked with the students about this yesterday. Prior to the Affordable Care Act, there's some statistics out that said uninsured in this country was a little bit better, or greater than 17%. Now it's about 13.4% the last I looked at it. So we could think about perhaps it's spreading and getting more access. But I also say to you that coverage, it's a problem. I tell you, it's a problem, but it's not the only problem as we deal with access. Got coverage, but I can't get over there to, I don't know, Ann Arbor. I don't have any transportation. So, you know, I encourage you to read this week's Time magazine. I like Time magazine, okay? This week's Time magazine, the front cover says, "What I learned from my $190,000 open heart surgery." And it's from a patient's perspective. It's a few pages. But it's chilling. Because when we're laying on that bed, looking up, and we're having whatever health problem it is, we don't care, do we? We don't care about price. We don't care about anything. And so even if you're uninsured, underinsured, all of these things, we have to have access. We pay for it one way or another. If I don't have a way to get to the pediatrician's office, and if I don't have, adequate, that's a different story, adequate health coverage, or any health coverage at all, I'm in your emergency room. And look at that cost. So we pay for it one way or the other. It just matters how you want to pay for it. What we have in this country is sick care and not health care. And until we change that paradigm and turn it upside down, and it's not going to happen very soon, and incentivize for healthy lifestyles and other things, we have a hard road to go. And you can see it. We spend more money per capita than most countries. And if you look at something like maternal and child births, we're on this end of the spectrum. So high price doesn't equal good, because we see that from other countries. Right? They're low price and they're better than us in some of these measures. So that's basically my comments about the Affordable Care Act. There's a lot to remain to be seen, lots of controversy and political emotions centered around it. Other questions? Yes?
I really liked, thanks. Your example of, addressing healthcare disparities by building pipelines for underrepresented minorities to become leaders in healthcare professions, because they're more likely to address healthcare disparities when they get there. But I was wondering, how do we engage people who aren't necessarily interested in addressing healthcare disparities to actually make a change? There are a lot of people who don't even think this is a problem. So, how do we get that on their radar?
Okay. So let me answer that question. I think everyone heard the question. So let me go back and correct something. What I meant to say is that if you look at the studies, underrepresented minorities, health professionals are more likely to practice in underrepresented areas. So it doesn't mean that they're the only ones practicing there, and I know you know that. A lot of times this is the areas. I talked to a student last night in pharmacy, and he wants to go back home. No, it wasn't pharmacy, it was dentistry. It was dentistry. And he wants to go back home and help out his community. So people return to their roots. Now, how do we get other people to be interested? You know, we all play roles. We all play roles. And we all have a role to play in this, whether it's on a political front, whether it's on the direct patient care front, whether it's advocating for it, we all could play different roles. But you have to care about it. Because those parents with the TV kids, they didn't think much about their maids coughing. Their problem, have a cough, you need to go see about yourself. You know, I don't got any money, don't have any money. Okay, well, all right. Now the kids have it. You got to care about it. You got to care about it. We are too mixed, moving place to place. Ebola in Africa, all of a sudden it's at Emory. We thought it was in Memphis, my guy. We just started making up stuff. You get scared. You have to care. I care about what happens over there, even if I have to go down to the least common denominator, which is my own selfish self. I don't want Ebola. Sounds like a problem. TB is a problem. So it's not their problem. It's all of our problem. So for pharmacy students, I go to ASHP mid-year every year. 30,000 pharmacists easy. So I come back every year, get a respiratory tract infection. My primary care physician asks me the same thing every year. Been around anybody who has a cold? Been around 25,000 people. Somebody had something. You sitting here today, me going to the airport tomorrow, me coming in here. You got to care about it. If you don't, you're taking a very myopic view. It will come back to bite you. I think I saw another hand, yes.
In talking about your MAP program, I just wanted to give a shout out to our own U of M program called Transplant Specialty Pharmacy. We were addressing the same problems of access and cost and all of that. And we got to the final hurdle, which was that a lot of local pharmacies don't carry those specialty drugs. So we actually have our own mail order pharmacy here. It ships out of the East Ann Arbor facility, and it has grown tremendously in the last 10 years. It's a huge success, so good that Transplant actually lost it and pharmacy took it over, and now they're going to spread it to things like rheumatology that also have very specialized drugs. So that I just got a shout out to anybody who's involved in that program, that we did it well.
Absolutely. Congratulations. It works well with oncology too.
All right, thank you, everyone. We've got a reception out in the lobby here.
Thank you.
Food and drink, so please join us. She'll be there for some more questions. That's awesome. Thank you. I really like it. Put a little protector on there for you.
That's why I have no clothes to wrap this. You don't need any. I have layers, man.